Hi, Dr. Ben Weinberg from the Rouge Center this week talking about the results of the phase 2 IMHOTEP study. This is a French study looking at patients with mismatch repair deficient or microsatellite instability high, locally advanced non-metastatic colorectal cancer. They enrolled 81 patients, most of whom had either T3 or T4 node positive colon cancer. They received one or two doses of neoadjuvant or pre-op pembrolizumab given 400 milligrams IV every 6 weeks, and then with a plan to complete a total of 9 infusions for a full year of pembrolizumab. And the results were quite striking, an over 50% pathologic complete response rate at the time of surgery, and only 3 of 72 evaluable patients had recurrences following surgery. None received chemotherapy. And at 2 years, only one patient was not alive, and that was thought due to a non-cancer related cause of death. So, quite impressive results, giving either one or two cycles of pembrolizumab pre-op, followed by a completion of a year's worth of pembrolizumab post-op. This is in context with the Niche 2 study that gave one dose of nivolumab, ipilimumab, and a second dose of nivolumab pre-op, and then no adjuvant therapy post-op, with also very good results. And the Atomic study looking at phase 3 post-op of giving chemotherapy FOLFOX with a different PD-1 agent, atezolizumab. So it's a bit of the Wild West. We have a number of options, not very large clinical trials, but pretty decent phase 2 data suggesting that patients should probably receive neoadjuvant immune therapy, either nivolumab, ipilimumab, or pembrolizumab, and then the question of whether to continue in the adjuvant setting as they did in this study. But clearly, these folks seem to benefit more from immune therapy, probably less benefit from chemotherapy, and more data of giving neoadjuvant immune therapy for this patient population.